Hi everyone. So in our previous lectures, we have already covered up to keratinized mucosa, and today I'll be talking about non-keratinized mucosa. So we know that the non-keratinized mucosa, it is divided into lining mucosa and specialized mucosa. So the questions are mainly framed from the specialized mucosa, and I'll be covering lining mucosa though, just for the sake of completion, as much as it's given in the textbook. But it is not very important. But the questions are rarely asked from this topic, so keep that in mind and mainly focus on the specialized mucosa. So I'll start up with the lining mucosa. Basically, everything else we have studied, okay? So everything other than the gingiva, hard palate, vermilion border of lip, and the specialized mucosa, everything other than this is the lining mucosa. So the lining mucosa, it is present in the vestibular fornix and alveolar mucosa. So these are the portion above your mucogingival junction or the mucosa. Okay. So the portion above this connecting your lip to kind of your gums. This is the vestibular fornix and the alveolar mucosa. Then it is present in the inferior surface of tongue and floor of oral cavity. Okay, so the lower surface of tongue and the portion which makes the floor, so the portion below your tongue, that is the and that is also lining mucosa, covered by lining mucosa. Okay, then there's soft palate and lip and cheek mucosa. So this is everywhere lining mucosa is present. So the only one that is given in slight detail in the textbook is the lip and cheek mucosa. So I'll be covering it. So the lip and cheek mucosa, and the epithelium, it is stratified squamous non-keratinized. Okay, so this is the type of epithelium present. Then the lamina propria, dense connective tissue, short irregular papillae. So dense connective tissue, okay, that's fine. But the main point to remember is that it has short papillae. Okay, the papillae aren't very long. We saw long papillae in the masticatory mucosa, but here they are short. Okay. The submucosa. The submucosa connects the lamina propria to the thin fascia of the muscles. So underneath this submucosa, there is muscle present. Okay. So which muscle is present? So this could be either buccinator in cheeks. So in case of cheeks, this would be buccinator, and in case of lips, this would be orbicularis oris. Okay, so this is the muscle present underneath the submucosa, right? So what does the submucosa do? This is the submucosa. It connects your lamina propria to the muscle underneath. Now it contains densely grouped collagen fibers, which limits its mobility. We see these collagen fibers. These are present in the submucosa, and what's the function? They do not let this mucosa move. Okay, and why is that important? This is important because when we're eating, we don't want our lips and cheek to come in between your teeth. So it limits the mobility of the mucosa, which prevents the mucous membrane from lodging in between the teeth during mastication. Okay. In between the strands, there is loose connective tissue. So this is loose connective tissue containing fats and mixed glands. Okay. So there is some fats and mixed glands present. Mixed glands are present in the lips only. Okay. So this is the structure of the submucosa, right? In lips, mixed salivary glands are present in the submucosa, okay, whereas in the cheeks, the glands are larger and are found in between bundles of buccinator muscle or on its outer surface. So in lips, we find these glands. You see these glands in here. But if this was a cheek, if this was a diagram of the cheek, you would find these glands somewhere over here, okay, or in between two band of the muscles, two muscle bands, okay. So this is what that is saying, right? Now then we have something called the Fordyce spots, and what are these? These are isolated sebaceous glands, okay, situated in the cheek, lateral to the corner of mouth, opposite molars. So these are basically just sebaceous glands, and this is mentioned in the textbook, so it could be important, right? So these are the Fordyce spots. Okay. So this is it about lip and cheek mucosa and lining mucosa. Now moving ahead with the main topic, that is the specialized mucosa. So specialized mucosa includes the dorsal lingual mucosa, which is the dorsum of the tongue. Right. So the upper portion of the tongue, this is specialized mucosa. The inferior portion, the portion like underneath this, that was lining mucosa. That was covered by lining mucosa. Okay. So starting with this, and the superior surface of the tongue is rough and irregular. So we all know that. We've all seen that. Okay. It is divided into anterior part and the posterior part. So the anterior part, this is the anterior 2/3 part, okay, and this is the posterior 1/3 part. Now this is divided using a line, a V-shaped line. This line is called uh, sulcus terminalis. Okay, so terminal sulcus. This is the line dividing the tongue into anterior and posterior parts. Okay, the anterior part is supplied by lingual branch of trigeminal nerve, whereas the posterior part is supplied by the glossopharyngeal nerve. So if I have to draw it over here, on the anterior part, this has a different nerve supply, and the posterior part has a different nerve supply. So what is the nerve supply? The posterior part has a nerve supply of glossopharyngeal nerve, and the anterior part has blood supply of lingual nerve, and lingual nerve is a branch of trigeminal nerve. Okay, and why do they have different nerve supplies? So that both the parts, they are made up of, they come from, or they originate from different arches. Okay, so we all know that in embryology, when we have a fetus, when we have a developing embryo, it is divided into various arches. Okay, and then each arch forms something else. So these two parts, they are formed from different arches. Okay, that's why they have different nerve supplies. Okay, so they arise from different arches. And then the foramen cecum is the remnant of thyroglossal duct. So remember, we have a structure over here, okay, on the sulcus terminalis, and that is called the foramen cecum. It must be highlighted over here. Okay, it's not mentioned. I'll just write it down. There's a structure over here. This is called foramen cecum. Foramen cecum. Okay, and that is the remnant of the thyroglossal duct. Okay, so but there are other structures as well. So this is the epiglottis, this portion. This is the epiglottis. Okay, this is the palatopharyngeal arch. Not very important, even if you don't remember it, it's fine. Then we have palatine tonsils. Okay, remember this is like everything that is contained in the posterior part. The posterior part extends from here to here. Okay, then the main part, the posterior part contains a lot of lingual tonsils. Okay, so the posterior part, we saw that behind the terminal sulcus, we have the posterior part. This first it has lingual tonsils, then it has this arch. Okay, then we have palatine tonsil, and it ends with the epiglottis. Right, this is the structure of the posterior part. Now coming to the anterior part, okay, so we have this terminal sulcus, we had foramen cecum, we saw that. Now the anterior part has papillae, and there are four types of papillae. First, we see these huge papillae. Okay, these ones are called circumvallate papillae. They are present just near this sulcus terminalis. Okay, then we have foliate papillae. So you see these arches towards the end on the lateral surface. These so there are some papillae that are in between these arches, and those are called foliate papillae. Okay. Then we have this median sulcus of the tongue. Okay. And then on the entire surface of the tongue, these rough surfaces and these rough structures. Okay. This is contained of, this is made up of fungiform and filiform papillae. Okay. There are four types of papillae. We know we have valate, circumvallate papillae, foliate papillae, fungiform papillae, and filiform papillae. Okay, so these are all the structures, and then the nerve supply, we already saw that. Okay. Now moving ahead, um, this was the basic structure. I'm talking in detail about the anterior part. Okay, so the anterior part, it is also known as the papillary part. Okay, it contains tiny projections called the papillae. So what are papillae? Papillae are epithelial projections containing core of connective tissue. This is the definition of papillae. What this basically means is, so they are just projections of the epithelia. Okay, projections means like something that is kind of coming out. Okay, and then the core of this papillae, it is made up of connective tissue. This is all the definition means, right? Moving ahead, the covering epithelium, it is keratinized. So this epithelium of the papillae, it is keratinized in nature. Now the types of papillae. So we know that there are four types of papillae. We already saw that. We'll discuss it in details. First, we have filiform papillae. Okay. So the filiform papillae, they do not contain taste buds. Okay. These are the only papillae that do not contain any taste buds. Okay. Then the other papillae, right, I'll just highlight. And then we have fungiform papillae. So the fungiform papillae, they are mushroom shaped. They are reddish in color, and because they are reddish because their epithelium, this epithelium is very thin. Okay, so they appear reddish because the capillaries are visible, so they appear reddish. Okay, so they're mushroom shaped. They're reddish in color, and they contain 1 to 3 taste buds. So if you see over here, this is the fungiform papilla. So it is like roundish in shape. Okay, and it contains these taste buds. If you kind of zoom in, you will see this labeled as taste buds, and it has like 3 taste buds. Okay, and if you look at this one, is the filiform papilla, so it has no taste buds, and it is kind of like cone-like in shape. Okay, now coming to the valate or the circumvallate papillae, these are found in front of the V-shaped sulcus, the sulcus terminalis. Okay, now they are 8 to 10 in number. So we saw over here. These ones, they are total 8 to 10 in number. Okay, they do not protrude above the surface of the tongue and is bounded by deep circular furrow. So if you see all the other papillae, they are coming out of the surface of the tongue. Okay, but this one, this is the circumvallate papillae. This is the surface of the tongue. Okay, but this is contained within the surface of the tongue. Okay, so this is one of the features. Okay, it is bounded by deep circular furrow. So this is the furrow that binds the papillae. They contain numerous secondary papillae. Okay, so there are like numerous papillae coming out of this one. Okay, and taste buds. So there are many taste buds present. Ducts of small serous glands called Ebner's glands open into the trough, which are the main source of salivary lipase. So basically, what this means is, so there is some glands, okay, and their ducts open into this the trough of this papillae. Okay, so over here, so these ducts will open in here somewhere, and these are the ducts of glands called Ebner's glands. Okay, and these glands, these are the major source of salivary lipase. Okay, just use a different color. So Ebner's glands, and these are the main source of salivary lipase. Now the last one we have to discuss. This is the foliate papillae. Okay, they are found on the lateral border of the tongue. So we discussed that foliate papillae are present like over here. Okay, they are found on the lateral border of the tongue in the large papilar clefts, and they contain taste buds. So there is nothing special, nothing new. These are found in the clefts of the tongue on the lateral border, and they have taste buds. Right. So this was all about the anterior part. So we have covered this portion. Now we will be talking about the posterior part, this portion. Okay. So if you look, and I'll just go back to the diagram. If you look at the posterior part, right, I'll remove this. The main feature that is present in the tongue, it is the lingual tonsil. Okay, so these projections, these huge, big projections, this is the lingual tonsil. So in the posterior part, the lingual follicles form the lingual tonsils. So these structures, those lingual tonsils, they are made up of the lingual follicles. And what are lingual follicles? These are round prominences containing lymph nodules and a germinal center. So lingual follicles, these are the structures which make up the lingual tonsil, and they look something like this. Okay, so they are prominences. They contain these lymph tissue. Okay, they contain these lymph nodules, and they have this big cleft in between. Okay, so this is the lingual follicle. Now, lingual crypts. So this cleft in between, this is the lingual crypt. The small pits present in the lingual follicle. This is lined by stratified squamous epithelium. Okay, so this epithelium, it is the stratified squamous epithelium, and ducts of various lingual mucous glands, they open into these crypts. So the various ducts, they will be opening into these crypts. So this is basically what the lingual tonsil is made up of and the structure. Okay, this is not very much important. The main part was the anterior part. Okay. Now coming to another important topic, that is the taste buds. So we know that these filiform papillae and not the filiform papillae but the fungiform papillae, foliate papillae and circumvallate papillae, they contain taste buds. Okay, so we have to discuss the structure of these taste buds as well. So what are taste buds? And this is a definition. These are small, ovoid or parallel shaped intraepithelial organs. Intraepithelial means within the epithelium. Okay, these are about 80 micrometers high and 40 micrometers thick. Okay, they extend from the basal lamina to the surface of the epithelium. So this is the definition of a taste bud. Okay, uh, sorry, this shouldn't be parallel shaped. This doesn't make any sense. This should be barrel shaped. Okay, just correct it. Barrel shaped. B-A. Okay, so these are barrel shaped. What does a barrel mean? Barrel means basically kind of like a structure like this. Okay, so this is not exactly called. This is a barrel. Okay, so these are barrel shaped structures. Okay, barrel shaped intraepithelial organs. Right. So this is the structure of the taste bud. Now, this going in detail. This is the definition. Now going in detail. Structure. So the structure, the outer surface is covered by a few flat epithelial cells surrounding a small opening called a taste bud. So if you look over here, this is the outer surface. Okay, this is covered by some epithelial cells. Okay, so there are like some flat epithelial cells present over here, up to here, over here. Okay, so these are the flat epithelial cells, and this is the taste pore. Okay, so taste pore is basically just a pore. Okay, and this taste pore leads you into a space where we have these supporting cells. Okay, so over here it says receptor cells, but remember there are three types of cells present within the taste buds. So first we have some outer supporting cells. Okay, then we have some inner supporting cells, and then in between the inner supporting cells, so if I have like two inner supporting cells, I will have these taste receptor cells. Okay, so there are three types of cells that are present within the taste buds. So the outer surface, we had these epithelial cells and taste pore. Right, the taste pore leads to a space which is lined by the outer supporting cells and the inner supporting cells. So we have these two types of cells, and the inner supporting cells are short and spindle shaped. They contain 10 to 12 neuroepithelial cells in between them. Okay, so these are the neuroepithelial cells. These neuroepithelial cells are the receptor of taste stimuli. So these yellow colored neuroepithelial cells, these are the ones which will detect taste. Okay, so these are receptors of taste stimuli, and then we have this nervous network present beneath the taste bud. All right. So this is it about the structure of the taste bud. Now going to the very last topic of this lecture, that is taste sensation. So there is this classic theory we have all studied in childhood, that we detect like sweet taste on the tip of our tongue, sour on the lateral side, okay, on in the posterior lateral side. Then we have bitter taste detecting ability on the posterior side, and salty on the anterior lateral side. Okay, so this is the classic taste theory. Now, how this correlates with our taste with our papillae. is that the theory suggests that we detect bitter taste through valate papillae, okay, sour through foliate papillae, and sweet and salty through fungiform papillae. Okay, so this is what the theory says. It is not entirely accurate, but we also know that the valate and the foliate papillae, they are supplied by glossopharyngeal nerve. Okay, this is the posterior part, and then the fungiform papillae, which detect sweet and salty taste, they are supplied by intermedial facial nerve, or you can just write chorda tympani. Okay, so you don't have to go into that detail. Just write chorda tympani, right? So this is supplied by the chorda tympani. We're talking about gingival sulcus and dentogingival junction, and these topics are mainly asked in short answer. Okay, so starting with the gingival sulcus. So I have already discussed what gingival sulcus is. It is the space between the inner aspect of gingiva and the tooth. So this space you can see over here if I zoom in. So gingiva kind of goes like this, right? So this was the free gingiva. We have already seen that. So this space between gingiva and the tooth, this is called gingival sulcus. Okay. The sulcular epithelium is non-keratinized in humans. It lacks epithelial ridges and is thinner in the epithelium of gingiva. So what this means is that this epithelium, the epithelium of this gingival sulcus, it is non-keratinized in humans. Okay, so this is not keratinized, this epithelium. Okay, and it lacks epithelial ridges. So the ridges we used to see, these are absent. These are not present. It forms a smooth interface with the lamina propria. Okay, the average depth of the gingival sulcus is around 2 millimeters. So this is around 2 millimeters deep. And if it goes deeper than this, then we generally have something called a periodontal pocket. Okay. And it is mainly due to some disease. Okay. So moving on, the next topic is gingival junction. So what happens in what we'll talk about in dentogingival junction? We'll talk about this epithelium at the dentogingival junction, and then we'll talk about development of the dentogingival junction. Okay, so dentogingival junction is a junction between the gingiva and the tooth. So the point where the gingiva and the tooth meet, this is the dentogingival junction. Okay, the epithelium of the gingiva which gets attached to the tooth is called junctional or attachment epithelium. So this portion of the gingiva, okay, the blue portion you see over here, this is the junctional epithelium. So basically the epithelium which gets attached to the gingiva, to the tooth, and the epithelium of the gingiva which gets attached to the tooth, it is called the junctional epithelium, okay, junctional or attachment epithelium. The junctional epithelium resembles the reduced enamel epithelium in structure. Okay, so the structure of this blue colored enamel epithelium, it is similar to the reduced enamel epithelium. If you don't know what reduced enamel epithelium is, so basically when we have this tooth erupting, okay, so after the tooth formation has taken place, the enamel, so this is the amygdaloblast, okay, the amygdaloblast on the top, they form a structure that is called reduced enamel epithelium. So they basically kind of form a layer over the tooth like this, and this layer is called reduced enamel epithelium. Right. So this junctional epithelium, it resembles the reduced enamel epithelium in structure. Okay. And what is the structure like? It is a basal layer with a few layers of flattened cells. Okay, so there is this basal layer present, and then it has a few layers of flattened cells. These cells. Okay. Other than this, if I talk about this in here, right, the junctional epithelium extends up to 2 mm on the surface of the tooth. So this is about 2 mm. Okay, junctional epithelium extends up about 2 mm on the surface of the tooth. Okay. It has highest turnover rate of 5 to 6 days. Okay, so it regenerates very readily. So it like gets produced very fast. Okay, the junctional epithelium is highly permeable. It is highly permeable. Why? Because it has large intercellular spaces between them. So you see this space, like white space, everything. These are the intercellular spaces, and they have huge intercellular spaces. So what this helps in is that first, because of these intercellular spaces, what you can have is just a second, you can have bacteria. You can have bacteria getting into this epithelium, and it can cause various infections. Okay, but other than this, you also have protection. You have protection. How do you have protection? So you have various neutrophils. So you have various neutrophils that have an easy passage in and out of the epithelium because of the intracellular spaces, and it also permits the flow of cervical or gingival fluid. Okay, then Langerhans cells, they can also migrate to this epithelium in case of infection of inflammation. So what in general what happens is that because of these intercellular spaces, this junctional epithelium provides an easy passage to the bacteria. But along with that is it also has great immunity because of these neutrophils and Langerhans cells. Okay, so they also provide great immunity to this junctional epithelium. Now moving ahead with the development of the dentogingival junction. So how does the dentogingival junction develop, right? When we talk about it, this is the tooth. This is we have this tooth, and after the tooth, the entire formation has taken place. We have this. This was the layer called inner enamel epithelium, if you remember. Okay, so this is the inner enamel epithelium which had an ameloblast. Now, after the entire tooth formation has taken place, these ameloblasts they form a layer. They reduce themselves into a layer that is called the primary cuticle. Okay, so they form something called the after enamel formation, the ameloblasts form something called a primary enamel cuticle. Okay, and this entire enamel organ, if you see the blue structure, this is the enamel organ that reduces itself into the reduced enamel epithelium. Okay, so there are two structures formed. First, we have the primary cuticle, first layer, and then we have the reduced enamel epithelium. Both these structures form a layer over this tooth. Okay, this tooth. Then the tooth is now erupting. Okay, it is going up. Now it meets the oral mucosa. So when it meets the oral mucosa, when the tip goes into the oral mucosa, it fuses with the oral mucosa. Okay. So the reduced enamel epithelium and the oral mucosa fuse. So we have this layer called reduced enamel epithelium, the blue layer. It will fuse with the oral mucosa, right? The remnant of the primary enamel cuticle after eruption, this is called the Naismith's membrane. So we studied this in enamel as well. So what Naismith's membrane is, it is basically a remnant of this primary enamel cuticle. So if somehow it remains over the tooth, it is called Naismith's membrane. Okay. So moving on with the development. So the oral mucosa and the reduced enamel epithelium, they fuse together. Okay. And then now the tooth keeps erupting. Now what will happen is that after the crown tip emerges out of the oral mucosa. So now the tip is emerging out of the oral mucosa. This reduced enamel epithelium, it is now called primary attachment epithelium. So you will notice that it has shortened, okay? It gets really short and condensed, and now it is called primary attachment epithelium after the tip of the tooth has emerged out of the oral mucosa into the oral cavity. So here we have oral cavity. After we can see the tip, now it is called the primary attachment epithelium. Now, after the complete tooth eruption has taken place, okay, so this is my enamel covered crown. The enamel will extend to somewhat like this. Okay, the gingiva covers a great portion of the enamel, right? So, one third of the enamel is covered by the gingiva. So, after the complete eruption has taken place, uh, the gingival sulcus. So, you see, this gingival sulcus has developed, okay? So, this portion which is attached and the portion of the gingiva which is attached to the tooth, we have the primary attached epithelium over here. So this blue color portion you see on the enamel attached to the enamel, this is the primary attached epithelium. Okay, so the gingival sulcus is bounded by the attachment epithelium at its base. So you see the if I zoom in, you see that the sulcus is ending over here, and over here what else do we have? So this is the sulcus, it is ending over here, and over here we have this primary attachment epithelium. So this gingival sulcus is bounded by this primary attachment epithelium at its base. This will go around the entire tooth along its circumference. Okay. So this is how the dentogingival junction develops. Okay. Now moving ahead to with the shift of dentogingival junction. This is another short answer question topic. What is happening is that your gingiva won't remain at the same place for your entire life. So first we have, I'll just read over the introduction first. The position of gingiva on the surface of tooth changes with time. Okay, when the tooth first reaches the plane of occlusion, one third to one fourth of the enamel still remains covered by the gingiva. I'll explain this. And there are three other eruption processes. Okay, so first is active eruption. It is the movement of tooth towards the occlusal plane. So what is happening first? I have this tooth. Okay, this is tooth of a baby. The baby has no tooth right now. Now the tooth is erupting. So this tooth will go up the oral mucosa, right? It will go up like this, and it will reach this plane of occlusion. So when the tooth reaches the plane of occlusion, what is happening is, so you can see that one third of the enamel, so this blue portion was enamel, right? One third of this enamel portion is covered by the gingiva, right? So this is called active eruption. So when the tooth is going towards the plane of occlusion, right? Now the second is passive eruption. So what is happening in passive eruption? We saw this attachment epithelium, right? So this attachment epithelium must also be present over here. So it must also be present like over here and over here. Now what is happening in passive eruption is your oral mucosa, uh, it will start moving downwards. Okay, so it will move downwards like this because of age or something or some pathology. So this oral mucosa will start moving downwards. Now this primary epithelium, attachment epithelium, this will also recede. Okay, then this will also move down. It will also come over here. It will move along with the gingiva. So this is called passive eruption, the separation of the primary attachment epithelium from the enamel. So this will move down so much that now you can see it is attached to the cementum. It used to be up here. It used to be attached to the enamel, this primary enamel epithelium, but now it is attached to the cementum. So this is the passive eruption. Now there is secondary attachment epithelium. What is this? So after this has come to the cementum, the primary attachment epithelium. After it has come to the cementum and the gingiva has receded too much, this was like similar to reduced enamel epithelium, right? But now it will change. It will change its structure, and gingival cells will replace it. Okay, so this will be derived from the replacement of the primary attachment epithelium by the cells derived from the gingival epithelium. So what was, just if you go back, so this primary attachment epithelium, it was derived from the enamel organ. It was derived from the reduced enamel epithelium. What will happen with the secondary attachment epithelium? This structure will be lost and some cells from gingiva, okay, so some cells from the gingiva, they will come in and they will replace this primary attachment epithelium. So this is secondary attachment epithelium. Okay, this will be formed when the gingiva has receded too much. Now there are two other terms. First is the anatomical crown and second is the clinical crown. So what is the difference between anatomical crown and the clinical crown? I have this tooth, okay. Um, I'll just make a better teeth. Okay, so I have this tooth. This is the crown, this is the root, okay. So this is my anatomy. So if I, this portion is the enamel covered portion. Okay, this is the enamel covered portion, and then the bottom is the cementum. This is the root. So my anatomical crown is this portion. Whatever portion is covered with the enamel, this is my anatomical crown. And what is the clinical crown? So if I have this, I'll just take this one, this mucosa. Okay, so I have this mucosa. Now, if this much portion is covered by the gingiva, so only this much portion is my clinical crown. Okay, if this much portion, if my gingiva has receded and now this much portion is visible in the oral cavity. So this is the clinical crown now. So whatever portion is visible in the oral cavity, that is the clinical crown, and the enamel covered portion, this is the anatomical crown. Okay. Now moving ahead with the stages of crown exposure. So this is basically how your gingiva recedes in the cavity. Okay, stages of crown exposure is your recession of gingiva. So there are four stages of crown exposure, and this is the same as passive eruption. Okay, so passive eruption was this recession of gingiva. This is same as passive eruption. So there are four stages: first, second, third, and fourth. Right. So what is happening in the first stage? There basically you have to consider 3 points. First is the position of your bottom of gingival sulcus, okay, this position. Then and the position of reduced enamel epithelium and the size of the anatomical crown and the clinical crown. Okay. So just remember this: the first and second stages, these are normal, and this recession can happen due to age. But the third and fourth stage, these stages are generally due to some pathology. Okay, so this should not be considered normal. Now, in the first stage, the bottom of the gingival sulcus, it is at the enamel portion. Okay, so this is still at the enamel covered crown portion, and the reduced enamel epithelium, it is at the cemento-enamel junction. So you see that the reduced enamel epithelium, it is ending at the cemento-gingival junction, right? It is not going beyond at the cementum. The anatomical crown, it is greater than the clinical crown. So my anatomical crown, my anatomical crown, this should not be great, is this entire portion, right? But my clinical crown is only this much. If I take the gingiva, so my gingiva is extending up to here, so my clinical crown is only this much, right? So the anatomical crown is greater than the clinical crown. Then in the second stage, uh, so this much recession, or this is the normal position of the gingiva. So it you'll see this at up to the age of 20 years generally. Okay. Now in the second stage, what is happening that the bottom of the gingival sulcus, it has now shifted like downwards. Okay, it is still at the enamel. It has not gone beyond the enamel, but it has shifted downwards. Now the reduced enamel epithelium and the apical end is on cementum. So over here, the apical end means the bottommost end, like the bottommost portion. It was at the cemento-enamel junction, but now it is on the cementum. This apical end, yes, it is on the cementum over here, right? Now, still the anatomical crown is greater than the clinical crown because the gingival sulcus is present on the enamel. So the gingiva is extending up to the enamel and it will cover some portion of the enamel. So this is my clinical crown and my anatomical crown was up to over here. Okay. Now in the third stage, what has happened that the gingival sulcus, it has shifted to the cemento-enamel junction. Okay, so this is the cemento-enamel junction and the bottom of the gingival sulcus is over here and the reduced enamel epithelium is now completely on the cementum. Okay, so right now because the enamel covered portion is on is up to the cemento enamel junction. So if this is my enamel, it will end over here. So in this stage, and this is my cementum, the anatomical crown and the clinical crown, they are equal. So this is my anatomical crown, the enamel covered portion, and you can see since the gingiva is extending up to here, so even my clinical crown is up to here. Okay, so they are equal in the third stage. Now the fourth stage, uh, the gingival sulcus, it may go beyond the cemento enamel junction, so it can in this stage we can see some root exposure. Okay, which is really bad. So we can see some root exposure in this stage, and now your gingival sulcus, the bottom of the gingival sulcus, now it is on the cementum, and your reduced enamel epithelium, it is also on the cementum, and the anatomical crown, now it is bigger than the clinical crown. How is it bigger? So I have this enamel covered portion, which is my anatomical crown, okay, and then I have this cementum. So this is my anatomical crown, and my clinical crown is now up to here. So since the gingiva has receded so much, this is my clinical crown, which is bigger than my anatomical crown. I'll be discussing the 8 changes of the oral mucosa, and along with this, we'll talk about some of the clinical considerations of the oral mucosa. Okay, so starting with the 8 changes, as we grow old, the oral mucosa it becomes smooth and dry. Okay, so that is one of the changes that takes place. And why does that happen? It becomes smooth and dry because the epithelium layer it becomes thin. Okay, the epithelial ridges they decrease, so it kind of becomes smooth. If you have this epithelium and you had these ridges, so these ridges they will kind of become smoothened out. Okay, they will smoothen out, and then there is the salivary secretion decreases. Okay, so this is why the oral mucosa becomes smooth and dry. So you can see this tongue that is very dry and very smooth. Okay, and then the filiform papilla reduces. So because of this, the tongue becomes smooth, right? You can see some varicose veins. Okay, so they are also normally visible, but they become more prominent. So these are the varicose veins, and they appear on the ventral surface of the tongue. Okay, so this is one of the changes, and it is called lingual varies, right? Now, the cell-mediated immunity also decreases due to decrease in the number of Langerhans cells. So, Langerhans cells, it is one of the non-keratinocytes. We discussed that. And then, in general, in the overall open mucosa, oral mucosa, the fibrous content increases. Okay, so there will be various structures that will degrade themselves into fibrous tissue, and it also affects the nervous system. Okay, so because of them the nervous tissue getting affected, you can sense some loss of sensation, loss of sensitivity of thermal sensitivity, chemical sensitivity, and mechanical stimuli. So you will lose somewhat sensitivity to all these stimuli. Okay, and along with this you will feel a decrease in the taste perception as well. Okay, so this is it about the 8 changes. Now moving to the clinical considerations. So what all diseases or factors you can see in the oral mucosa. So starting with the periodontal pocket, it is very obvious one. So the periodontal pocket develops when there is deepening of the gingival sulcus, and it happens due to plaque and the toxins they release. Okay. Uh, if the pocket gets too deepened and the junctional epithelium gets detached, okay, that is a sign of periodontitis. Okay, so that is a hallmark of development of periodontitis. Now, anti-cancer drugs may cause ulceration of the oral mucosa due to high turnover rate. So we know that anti-cancer drugs they affect the tissue with high turnover rate, and that may cause ulceration of the oral mucosa because it has very high proliferation rate. Again, in metal poisoning, so especially in lead and bismuth poisoning, you can see a characteristic decoloration of the gingival margin. So if I zoom in over here, you can see this, it will appear like a bluish line. So this decoloration, it is due to metal poisoning. Okay. Then there is something called Koplik spots. So these are like whitish spots on the side of your cheeks. Okay. Whitish spots with bluish centers. No, sorry, bluish spots with whitish centers, and they appear in the first stage of measles. Okay. So this is like visible even before the skin rash. It shouldn't be rash, skin rash appears. So these spots are like very important for diagnosis of measles because these are like one of the first signs that would appear in case of measles. Okay. Then in scarlet fever, we observe something that's called strawberry tongue. The tongue will get really red and it will have like whitish protuberance, whitish spots. So that is a sign of scarlet fever. Okay. Then you observe magenta tongue and beefy red tongue in the case of vitamin B complex deficiency of pernicious anemia. Okay. And then the last one that is oral cancer. So oral cancer can take place due to it can take place when the expression of one of the following genes is altered. Okay, so we have these genes in our oral, we have these genes controlling the proliferation of our oral mucosa, and if some of the genes are affected, okay, so that will cause oral cancer. Okay, so with this we are done with the chapter of oral mucosa, and if you like the video, please like, share and subscribe. In the next chapter I think I'll be uploading eruption and shading. Okay, thank you.